Hi.
Hi,
Can you hear me?
I can. I'm just trying to get my camera to kind of stay still.
Okay.
Sorry about that.
No, it's okay because I'm like, oh, I wonder if she got my messages. And then I
I
saw you messaged me on IG too.
yeah, I was trying to just figure out the whole thing and managed to kind of figure out, but now need to get the camera to stay.
Yeah, no problem.
It's like the technical things. I know how to catch babies, but technology sometimes is a little bit more difficult. So
No, I
let's
know
see.
for me too. This is my first time doing all these lives, so I'm figuring everything out as I go along.
Okay. Oh,
Oh no.
no, we'll see. We'll see how it is. If you have younger kids with you, they kind of know how to figure this all out. So we'll
Yeah.
see if it works out. If not, I could always do the old fashioned and just put it to stand up against something. You know what? I might just do this, and we'll see. We're gonna improvise here and do it's kind of like a MacGyver style here.
Sometimes you got to do that.
You gotta figure it out. Give me 1 second just to find something.
Yeah, no problem. Don't worry.
Does that work? I think we
Yeah.
can manage. We'll see how it works.
Yes. I don't know. I think that's gonna work fine. But I want to know because this is really important to me. So, do I pronounce your name Shâdé?
Yes, exactly. Shâdé.
Okay, perfect. Because everybody mispronounces my name, so I'm always like, I have to ask a person instead of just assuming I know what it is.
Yeah. And how do I pronounce your name? Because I don't want to pronounce your name wrong either.
Oh, it's Lorena.
Lorena.
Yeah,
Perfect.
perfect. So, thank you so much for taking the time out to do this with me because I know that you're super busy.
No
So,
worry.
thank you so much. But this was actually requested because I do have people that are interested in becoming a midwife. So they had some questions as well. So I will get to that. But before I start the series of questions, if you could just briefly introduce yourself to everybody watching.
Yeah. So, hi everyone. My name is Shâdé Chatrath. My midwifery name is also known as Baby Catcher. Depending if I'm doing cosplay, then I'm Storm.
Okay.
But I am a registered midwife in Ontario. I've been a registered midwife now for about 10 and a half years. There's a lot of different reasons why I became a midwife and the path and the journey that I've come through, which I'll probably get into eventually. I work out of the GTA area, so I work predominantly in Toronto, Etobicoke, Rexdale area. I work with a practice called West End Midwives. I was the original new registrant, so a new graduate, and they've kind of nurtured me, and now I'm a senior partner at the practice. So I've been there, and it's like my home. We work out of Etobicoke General Hospital as well as Humber River Hospital, and we do home births in the community as well. I'm really passionate about my job. I think I love it a lot more than I did when I first began. And I feel like it's just a new level that I'm on, and the people that I want to help, the people that I want to support. Definitely really passionate about helping the IPOC community and just marginalized people and just helping people in general who really want to have a good experience. And so it's kind of my mission to kind of help to support them to the best of my ability. So I'll start with there and kind of let the secrets come out. You know, we got to get to know each other.
No, of course.
Keep
And then
people
too, like,
interested.
no, definitely. But if there is something that I don't cover that you find is important because you're the expert, so definitely let me know because I want people to have as much information as possible to help them. So my first question for you is if you can tell us what is a midwife and also like within that, maybe like what's the difference between a midwife and a doula? Because sometimes people who are not familiar kind of mix up the two when they're two very different careers or jobs.
Exactly. Yeah. So a midwife is what we call a specialist in healthy, low risk pregnancy, birth, labor, and postpartum period, as well as newborn care. So we feel like we know low risk, like that is our expertise. It's the back of our hand. It's the fundamental and foundation of how we provide care to people. We're really good at it, and we cherish it and all the things that we do for people. When it comes to just differentiating between a midwife and a doula, and I give props to them, they are amazing. They are not clinicians. So a midwife is an actual clinician. So if you take a person who is pregnant and they come into care, we're the ones who would be providing ultrasounds, blood work, genetic testing, for example. We would actually be doing blood pressure checks, monitoring the baby's well-being, the growth of the baby, for example. We would actually be attending and assessing the labor for them. We would also be doing the deliveries of the clients, as well as we would be following them in the postpartum, making sure all the recovery and the care up to that postpartum period, up to 6 weeks, including the care for their baby. So assessing the heart rate, the respirations for the infant, as well as the growth, assisting with breastfeeding. So it's more of that clinical management that we would be doing as midwives. So it would be kind of the same level as an obstetrician for those who might choose that path, as well as there are some family doctors that still do a little bit of practicing and do deliveries. So it kind of be that level. Whereas a doula is not a non-clinician. So basically they may have some of the knowledge, may have some of the understanding, but they kind of provide more of that spiritual, that cultural, that emotional, physical support. So depending on what type of doula that you hire, they may come just during the prenatal period and attend your labor. Some of them will do some check-ins postpartum, or there are some specific ones that focus on breastfeeding. They may help to cook and clean. So again, they may range from a variety of expertise and skills, but it's non-clinical. The other major difference that a lot of people don't know is that midwifery is actually covered by OPIP if you have OPIP, and as well as for people who are uninsured, their midwifery is also covered too if they're a resident of Ontario, whereas a doula, you actually have to pay out of pocket.
Oh, wow. Okay, so thank you for explaining that, because even I didn't know that last part either, that it was covered. Of course, I'm from Quebec, I'm from Montreal, so definitely if somebody is interested in that, definitely look into that for the coverage and stuff. I really didn't know that, so thank you. And then being a midwife, is that something that you always wanted to do? And if not, like, how did you discover this career path?
Yeah, so I'll say no. It was definitely not what I wanted to do necessarily. I always loved babies and pregnant women. It was just like I always had a doll. I was always taking care. I had that kind of nurturing kind of personality. And if I kind of look back at my life and kind of how it brought me to midwifery, the earliest memory of just kind of helping someone in labor was actually my mother. So I'm the oldest of 4 children, and I was at home with my mother. We had gone to McDonald's, and after a while, she felt really unwell. And so she thought she got food poisoning from the burger. And so she started to feel pain, but she was actually in labor. And I was only like 3.5 years old. So I was almost 4. And so I basically took initiative. I, helped her to get calm. And then, when we thought things were happening with the baby and if there was some concern, I helped to call 911. My father wasn't home at the time. And so I was able to push a chair to the door to help to unlock it and let the ambulance in. But at that time, that was kind of the time frame where, they didn't even let like the father into the room, for example. And so I was a little kid. Of course, they were not going to let the little kid come into the room. So there was just some kind of like not anger, but this protective mechanism in me where I was just like, that's my mom, and what are you doing? And that's my baby brother. And so just kind of that nurturing kind of thing when you see someone in labor and you see them in pain and you want to kind of be there and just make sure they're well taken care of. So I would say that's kind of the earliest journey. And so as I kind of navigated the system, I knew I loved health, I loved, physiology, biology, and so I just kind of navigated through school. But there wasn't really that calling and advertisement for midwifery yet when I was still kind of going to school. It still was kind of developing. And so as I kind of went through school, I was just like, I really want to be in maternity. I knew I didn't want to be a nurse. I knew I didn't want to be like a obstetrician. It was just how the model and the philosophy wasn't what I wanted. And so I kind of went on a career path of kinesiology. And so I loved health and fitness. I loved working with people. I loved training. And I knew it was kind of a stopgap until I could really figure out what it was. And so I went through that. I graduated and I worked in that field for a bit. And then I started to train some pregnant women, and I started to really like that and really enjoy that. And so I started looking around what other things. And then there was one moment where I went to actually forensic science because I love that kind of stuff, and maybe that's a whole different story. And so I started an application for that, but I was just like, I really want to be in this field. I really love to teach. I love to work with people. And then somehow midwifery came up. And when it came, I was just like, oh my gosh, this is a aha moment, like the light bulb just went off. And I was just like, this is it. This is what I've been looking for. And it felt crazy because I had a degree, I had a job, there was no real reason to kind of, start all over. But for me, it was just the calling. Like when I just looked at all the different things, how I would take care of dolls, how I would nurture, how I loved pregnancy and how I loved, babies, it just made absolute sense. And when I started to get more in about like the philosophy, what midwives do, it was just perfect. So then I went and applied through the education program. I went to Ryerson University. At the time, the way I entered and how the program has kind of evolved since then, but it's kind of similar. You have to get about a 75% in some core courses, so like your English, and so as well as like your math, and then one of like your sociology, so kind of like a women's studies. And then there's an application process as well. So at the time when I did it, it was kind of like an essay. They had a couple of questions. Once you kind of had the grades, you can go to the essay. Once the essay, they read it. Then there was like an interview kind of process. So there was a panel of people. Now it's kind of like almost like a bell ringer, kind of a bunch of interviews, mini interviews to kind of ask similar questions where they ask you about like lifestyle, how you would do in the program. And once you kind of pass that, then you can get you can get into the program at that time. When I applied, it was much more smaller in terms of how many people they were taking. So I was one of 19 people at that school that got into the program. So my first time where I applied, I actually was on a waiting list because it's a very competitive. And then the second time when I applied, I was one of 19 people that got into the program because they weren't allowing that many people. There are 3 schools in Ontario, and across the provinces and the territories, there's different ways how the programs work, but kind of similar. But in Ontario, there's 3 schools, Laurentian, McMaster, and then Ryerson University. You can apply to one of the 3 schools, but they work as one school. So you can't apply to Ryerson and Laurentian. You have to choose kind of like which one of those schools are going to be kind of like your home base.
And are all those schools, if are they all competitive? Like the program, it's really small, the amounts of people that they accept?
Yeah, so each school now at this particular time, so they have increased it, so it's 30 per school. So at the time when I applied, it was like about 19 to 20 max per school. And so the ministry, because of how midwifery work, the benefits to clients, the cost effectiveness of midwifery to society, as well as the healthcare system, they have kind of pushed for the school to kind of graduate midwives a little bit faster. So each school now does 30 each, which is a total of 90 graduates potentially per year. Doesn't mean that 90 people actually graduate because there are a lot of hoops and hurdles to get through the program as well. But that definitely helps to make the process better.
Okay. Well, I also want to say that's amazing, the story that you said in the beginning with your mom when she was in labor. So I think that's amazing because you were like 3.5 going on 4, and jump and take that initiative at such a young age is amazing. And then to see how it turns into you being in a midwifery now, to me, that's amazing. So kudos to you, and because I've never heard anything like that. Most people, when they see something like when something like that happens, they panic, they go into panic mode. But for a child to take that initiative and know to like calm your mom down, let the people in and get things going, that's truly amazing. I also wanted to know as well, because you did say like there's only 90 people that get accepted, doesn't mean that's 90 people that actually graduate. So would you say that there is a large need for midwives?
Absolutely. We have a high waiting list. And so if you think about 10 people, about 4 of them will kind of be turned away. Right. So it's really high waiting list because of the demand for midwifery is higher, and as well as the type of care that we provide. So the way we work is very different than a typical obstetric or a general practitioner model. So midwives believe in what we call pillars or models, however you want to kind of put it. We have 3 of them that are very fundamental to how midwives kind of practice. So the first one is informed choice. And so again, what that means is we're just going to talk to you. So, get used to your midwife kind of talking your ear off, but we're going to talk to our clients. We see them as the primary care decision makers. So rather than having this kind of doctor care, kind of patient care model, it's kind of like that person care, family care, centered care model. And so we're going to give them the information. So even something as simple as, we're going to do blood on you, right? So I'm going to do this blood test. This is what I'm doing. This is what it might mean. This is what the results might entail. If it comes back positive, are you okay with it? So we're really making sure that people understand what is happening to them, what is happening to their baby. We understand that sometimes, in certain cultures, like it's not the person who makes the decision, but maybe it's the auntie or it's the grandma. So, who is important in your care, and getting those people involved the way that is appropriate for you to make the appropriate decisions for your family. And so those little simple things have long meanings. And so people who are used to the medical model, like it's kind of weird to them. They're like, but you're my caregiver. Why don't you just tell me what to do? And it's like, no, we want you to be empowered. We want you to have an understanding. Even if you're still going to say yes, it doesn't matter. We want to make sure you understand why you're saying yes, right? We want you to understand that your pregnancy is not the same as the next person's pregnancy. And even if this is like your 5th kid, each of those pregnancies can be completely different, right? And so we want to make sure that for each pregnancy, we are kind of building some kind of care for that person for that particular pregnancy. The next model is choice of birthplace. So in Ontario, we do have birthing center, we do have hospital options, and we have home birth options. So depending on kind of the region is going to depend on like what you have available as well. So there are 2 Ontario birth center. One is in Ottawa, one is in downtown Toronto. So for example, our practice doesn't go to any of those because we're kind of not in that particular catchment. But we do work out of the 2 hospitals, like I said, and we also offer home birth. So it is a requirement just even to graduate that we have to do deliveries at hospital as well as home. So in order for someone to graduate from the program, they have to do at least 10 births. And I'm talking specifically more about the Ontario model. For people who are interested, they can go to Canadian Association of Midwives, where they talk about all the different provinces and territories of how you can graduate. And so you have to do at least 10 births in hospital where you're the primary caregiver, as well as 10 births at home, and at least 5 of those you need to be the primary caregiver. And that's just to make sure that you can offer those different options to clients. And we think that's amazing because if you really think of when clients get pregnant, and if they go to the hospital, and we know most people have their babies at hospital, sometimes that is the only time and the first time that they're actually being exposed to a hospital system. Most people, if you think of, if we're defining as women in particular, as caregivers, they don't take care of themselves. They tend to take care of others. So even if they're sick, if there's something that's going on, they usually don't go and seek medical attention for themselves, right? So they kind of brush it off, they push it off. So it's usually not until they're pregnant is the first time that they're actually seeking some kind of medical care and then being in a hospital setting. And so for some people, that is scary, right? So we make this assumption that a hospital is what everyone wants, and it's not. So we know that as midwives. And so for some people, home is natural, and home is a choice of a birthplace option that they feel comfortable to as well. And so by giving people different options that they feel comfortable, and we know what the research shows, we know that they're going to be more relaxed, and therefore they're going to not be as stressed, and therefore pain is going to be a little bit less. We know that they can maybe bring their family and have those people around them. That is going to be very important for them to have that birth experience. There's just different ways that they perceive how the labor is going to be and going. And so for different people, it's going to be different venues. If you're going to divulge into the benefits of home and hospital, we know home has less infection, for example, right? Less intervention. So different people are going to choose different things for different reasons. And I think one of the things that people don't know sometimes or assume is that if you have a midwife, you can only have a home birth. You can't have a birth at hospital. And that's absolutely not true. Like I said, we do have privileging at hospitals. And having a midwife in general, you're going to have lots of benefits because we are specialists in low risk, which means we're always looking for a low risk approach based on evidence and research, and we're not going to intervene unless it's really necessary. So you tend to have less interventions with midwives, less pain use. We have better rates of, babies that do really well. So we have higher APGARs, we have lower admission rates of babies going into the NICU. We have higher breastfeeding rates just because of our model of care as well. Less third and fourth degree tears. So those are tears that kind of go through the bum, for example. So I could go on and on, for example, but, there's definitely benefits. So people who are thinking, okay, if I'm a midwife, I can only be a home birth midwife, for example, or I can only offer home birth. In Ontario, that's not true. You do have the option to have a midwife, and they can do deliveries at home as well as hospital.
Okay. Oh, sorry, continue.
No, go on. Go ask me the questions. I could keep going because, it's just one of those things, you just talk about it and it's just in your soul and you just kind of start preaching. You start preaching, right?
Well, because I wanted to ask you, because you've been doing this for a while and you could tell that you're so connected to your work. So I wanted to know, what's the best for you? What's the best part of your job?
I would say it's the transition of the client. So it's almost like, I feel like it's a family, right? And I understand that sometimes you connect with some people more than others, for sure. And that's just in life, right? But it's kind of that transition, and it's that family dynamic. It's that culture, you're being invited into somebody's home, right? So they're telling you sometimes their deepest secrets, they're trusting you, they're divulging information that sometimes they can't even share with their other family too as well. Sometimes you're bridging things between the family, right? And you're navigating. As a midwife, I always feel like I'm just not a midwife. I'm like a nurse, because we do some nursing care. We do obstetric kind of care. We're social workers as well. We're, counselor. We're helping with mental health. We're lactation consultants. So we pick a little bit of every little thing, and then we put it into this amazing kind of, have canvas, and you get a midwife, right? You add a little pizzazz because we're pretty feisty too as well as midwives, and then you get a midwife. And so, when someone is transitioning, so I have lots of stories of just people who feel broken. They're just not sure how they're going to do. They have the anxiety, and then you come to the last appointment, and then you just see this person who is just feeling so strong and so empowered. Even if they don't feel it the same way, you just can see that transition. And it's like a butterfly, like a caterpillar that goes into a cocoon and then just morphs into this amazing, beautiful butterfly. It's almost like that. And I see these people and I'm just like, wow, you are so amazing and you are so strong. I think that's the best part of it. You just get to see that transition and you get to be there. I hate the goodbyes, of course. But,
Yeah.
it's hard. But then what I think of it in a way is like, here's another strong individual who can advocate now for themselves. They know what it's like to have someone who respects them, hopefully, and gives them information, doesn't make assumptions, and that they can challenge things. Even if, even when people challenge me, I try not to get offended. Like, there's always that part where you're like, but I'm your midwife. I know what's best, right? And you have to remember,
Yeah.
no, like, good, you're challenging me. Like when people say, I'm sorry, I'm asking lots of questions, I'm like, no, ask questions. You should know what's going on with you. You should know what's happening to your baby. So I love that when people can do that. And then they're going to go out, they're going to advocate for themselves, they're going to advocate for their babies. And then they can teach their families and their friends, like, look, you deserve to know what's going on with you, right? So the gossip that kind of comes off from it, right? Oh, I had a
Yeah.
midwife and I did this. Did you know what this test is about? Well, let me tell you about this test. So I love kind of seeing that. So that's the
I
best part
think
about it.
that's, sorry to cut you off, but I think that's
No.
great because a lot of people just put their faith and everything into like the doctor or what have you. And so whatever the doctor says, they just go along with it. They never question the doctor,
Mhm.
or they never even seek maybe a second opinion or ask too many questions because they just feel that that's the expert. So whatever they say is that. So I think it's really great that you guys are like educating your clients, the people that you work with, and also empowering them as well throughout their journey. So I think that's amazing what you and your team, what you guys do for women and for families. So I think that's really cool because a lot of times I hear people like, oh, well, my doctor said this. And I'm just like, maybe you should ask like a few more questions, just to make sure. But I think that's amazing. And then another thing I want to ask is that a lot of people get interested in certain careers, but they don't know the hard work that it takes within the career. They might just be like, oh, I just want to deliver babies, or like I want to work with just a woman that's pregnant, but they don't know maybe a lot of like the physical and emotional work that goes into it. So if you can, because I know every work day and week is different, but if you can just
Yeah.
briefly say like what goes on during a work week for you.
Yeah. So I would say it's a couple of different things. And it's going to depend on the person. It's going to depend on your support system for sure. Like what I would tell people, and it's not that I want to negatively not encourage people. We definitely need midwives. We definitely need more IPOC midwives as well. But it is not just a career. I would say it's more of a lifestyle. Like midwifery is part of my life and it is part of my family's life too. And they just have to understand how it works. So if you have small kids, if you're, dating someone, for example, if you have friends, those relationships are definitely going to be challenged. Like definitely I've lost friends because, I can't come out. So eventually they just stop asking, she's never going to be able to come out anyway, stop inviting her, right? Definitely if you have children sometimes, the kids are wondering like, why are you going again? Why are you doing this? Like, where are you going? So that can be definitely hard. For some kids, it's okay if they're used to it as well. Partners, right? Because now they have to, sorry, I think my camera's sliding a little bit. Just keep the excitement, see the clinic room. So for partners, sometimes it's challenging, right? Because they don't see you at the time. So, sometimes they can feel like kind of on the back burner because if you have a client who's in labor and that baby's ready to come, like you need to go. You don't have time to kind of do like, I love you, don't worry, I'll be back. Like you just got to go and they have to understand. And so sometimes it can definitely test some relationships. So in terms of just like the hard work that comes, it depends on kind of the structure that you have. So if you have a good support system, if you have someone who, like if you have young kids, can just come and watch those kids, it can definitely make the process much easier. In terms of the work, so for example, like last week, I was on call. I went to 5 different deliveries. They were some at home, some were in the hospital, some were first-time clients, some were having like their 5th or 6th baby. I had to do also assessments for those clients to see if they were in labor. There were some false alarms, so you sometimes are doing the back and forth. On top of that, we are doing checkups for them afterwards. So if you take those 5, usually on average, we do anywhere from 2 to 3 home visits. So that's 15 home visits in that same week as well for all those different clients. For example, if they happen to have their babies all at the beginning in my work week. On top of that, I'm assessing people who might have been bleeding, anyone who says, my baby is not moving, right? Giving advice in that time frame. So there's a lot of different things that are still kind of happening. Sometimes I'm getting paged at 4:30 in the morning or 2 in the morning because it's multiple labor assessments and multiple false alarms. So that's what I would call an average week. I've had busier weeks, if you want to believe it. My busiest week was that there was 14 babies, 14 deliveries, 10 of my primaries, and we also do backups. Backup is when we're not the main person responsible, but we are kind of like the baby midwife. So we come and help with the baby. We help with the listening once the primary midwife needs to do the deliveries. And so I had 10 primary deliveries and 4 backup deliveries, so a total of 14 births in 6 days. I made it to 11 of them. So that was the busiest day. And then in one day I had 10 postpartum visits because all of those primaries had gone. So that's a busy day. And then some weeks you can basically be there and nobody delivers because everyone delivered the week before. And so it can be a quiet week. So it kind of can be up and down. And I think that can be the challenge for some of the family members or for some people because it isn't this kind of steady thing. It is very sporadic and you just don't know. For someone like me, I love that excitement and adrenaline. I'm like, okay, we're ready to party. It's going to be a birthday party. Let's go. Let's see what's happening. And I think that's just because I've had many years now to kind of navigate. And I feel like now I have a rhythm. I know all the little kinks. I know all the things that make me a better midwife and the things that work for me. Whereas when you're still trying to figure those out, it's a little bit hard. It can be very challenging, right, to figure those things and navigate those things. And we do have a very high attrition rate and we have a lot of burnout because of the way that midwifery is kind of funded. And so just to kind of get into it a little bit, we are autonomous, which means we're self-employed. We don't work for like a practice or anything. We're self-employed, but we join with other midwives to kind of build a practice, and we're all kind of responsible. So we get paid through the Ministry of Health, and we do get paid by courses of care. So it's not kind of a billing system like the way the doctors work. So we take a client, we get billed for that client once we complete the full course of care, which is whenever they come in pregnancy, the labor and delivery, and then the 6 weeks course of care. And so because we're kind of like autonomous and because of the way we practice, so we're doing the prenatal care, like I said, we do our labor care, we do the delivery, we do the postpartum care, we take care of the baby. Those are things, if you think of kind of like the obstetrical model, you would have had a doctor who would have maybe doing the prenatal care. And then in labor, whoever happens to be on the floor might not necessarily be that person's doctor. It's the nurses that do kind of the labor support and the labor care. And they switch. So if you have a long labor, then, and it's a shift change, then you might get a few. If it's a shorter, then you might just get the one. They can take breaks, they switch out with people, and then the doctor, whoever's on call, kind of comes and does the delivery. Then there's like a pediatrician that kind of does like the baby care. You're kind of on your own in the world for a bit, and then at 6 weeks, you kind of do a checkup for yourself there. So all those different people, your midwife or your midwifery team is kind of doing that. We enjoy it. We believe in that because we believe in continuity of care, which I didn't get to talk to you so much to, but we know what the benefits is, right? We know when you have kind of that disconnected care, there's more likely going to be incidents. There's going to be, miscommunication that also happens. You're going to have to repeat yourself as a person. Sometimes you're going to get someone who kind of gets it, another person who doesn't get it, depending on kind of what the situation is. So there's just a lot of things that can kind of happen when you have that disconnection in continuity. But we believe that continuity is so important. And so because of that type of care, it does take a little bit more work and effort, but it's definitely worth it.
I think that I personally would prefer that to just have that same person that I've built that trust with and that relationship throughout the entire process, because I do find it to be a lot to have all these different people in and out the room and stuff like that. And then, like you said, different things can happen that's not really for the mother or the baby.
Mm-hmm. Yeah. Yeah. And it's hard and it's challenging, like I said, because you are doing the job of kind of a bunch of different people. Even if you work in a team setting, it is kind of challenging for that. But if you believe in the model, if you believe in midwifery care, if you believe that everyone who can have a midwife should have a midwife, then it does help the circumstances. But we know life happens. We know different things come and you don't have control of it. And so that's what it would make it very, very, very challenging. And, I will definitely tell you, when I was going through the education program and you're navigating all these different things, there was a point where I had to move from my family for a placement, and it was like, I'm out there by myself, in a strange place, because I want to take on this career. And I'm just asking myself, is this really what I want? Is this, what I need to do? And, you're students, and so you're vulnerable to as well. And you're trying to kind of navigate the system. You're trying to impress your preceptors. You're trying to impress the clients and trying to convince them that you are a midwife, but they only see you as a student. So you're like, why am I here? Should I be here? Am I good enough to be here? So there's a lot of those kind of hard work and challenges and reconvincing. And so for some people, they have more challenges than others. They face racism from clients. Sometimes they face it from their preceptors, the community. We know that BIPOC, IPOC students will have a little bit more challenges sometimes too as well. If you have other things like mental health issues too as well, and people don't understand and want to support, like the way the profession unfortunately is, sometimes it's hard and challenging, right? Because like I said, we're self-employed. So, we do have some benefits that cover some things, but sometimes it's not going to be the same as if you're on EI, for example, right? So,
but I want to know, because you work for yourself and you take on so many jobs, like how do you avoid burnout? Like what advice can you give to someone who may be starting out or wanting to go into midwifery? Like how can they try and avoid that, the burnout part of it?
Yeah, so as midwives, we can do kind of, different kind of, I guess, caseloads. So you can do like a part-time or a full-time. So kind of understanding like what type of caseload you want. There's different ways that practice as well. So there are some shared called models versus what we call primary call models. So a primary call model is basically, you're the midwife for a bunch of clients. You see them in the clinic, but if there's someone in labor, you may have to cancel your clinic and go out and do the delivery. So you will have X amount of numbers. So you're going to be on call more often because you're on call as an independent person, still in a practice setting for a bunch of clients. Whereas if you are in a shared call model, what we're doing, so let's say you're my partner, as midwives, we are basically, we're responsible for our clients, but what we're saying as an agreement so that, we can get a little bit more time off is, why don't I scoop your clients? We'll just call them our clients. And so you're still billing for X amount of clients. I'm still billing for X amount of clients, but we're going to collaborate together. And when I'm in the clinic, I'll do all the clinic stuff. You just be on call. Any of them who happen to go, we just call it a wash in the system. I'll do my clinic and then I can get some time off. And then in reverse, when you're in clinic, you see all your clients and my clients, which we call kind of our clients, and then I'll be on call. So we're kind of making almost like an agreement to take care of each other's clients so that we can have a little bit more time off. Because in the other model, you're just on call all the time. You're in clinic all the time, you're on call all the time. Whereas the other model, maybe 1 week you're in clinic, maybe the next week you're off call. And then if you want to go on holiday, I watch those clients for you and you can do like a 1 or 2 week holiday. So it's kind of a collaboration. And that's the model that most midwives will do, just because it will have a little bit more of work-life balance. Now, that was, primary call was like the model when midwifery first came out. You know, when people kind of advocated and when it kind of got regulated in 1994, the first program started, the first students happened in 1993. It was just a different bunch of individuals that were becoming midwife that had different needs. Now we're getting more of newer, younger generation of midwives, and there's just different needs. And then we also have those midwives who started at practicing that also have different needs. So there are some midwives who have decided, you know what, I can't be on call anymore. The model is a little stressful. I really love my job, but I need something different. And so there are alternative models that the government is giving some funding for, that people have come up with some creative programs. And so that has helped for some people to be able to still be practicing as midwives, but not in the traditional way that our college requires. And so those midwives would have to kind of get an application or apply for funding, and it has to kind of get approved in order to be practiced as that. So a midwife randomly just can't decide, I'm going to do this and I'm going to practice like this, because we still have to work within our legislation and the requirements as our midwives.
Oh, okay. And then also going back to the education part of it, besides doing the programs that you mentioned at the universities that you have in Ontario, are there also like certifications that somebody has to get outside of that, or maybe like continue to update those certifications as well?
Yeah, so when you graduate from one of the Ontario schools, for example, there are the requirements. So like I said, you have to do like at least 10 hospital births, you have to do 10 home births, 5 of them as primary. You actually have to attend at least 60 births, and at least 40 of them you have to be the primary caregiver. You have to have a certain amount of the continuity of care, so about 40 of them, meaning that as a student, you kind of see them during the pregnancy, attend their labor birth, and then take care of them in that period of the 6 weeks postpartum, so that you can actually say that you are the midwife. In addition to that, we have to do things like what we call neonatal resuscitation. So that's basically CPR specifically for neonates. We have to actually do that every year. And so that's a lot more frequent than the requirement. Usually pediatricians or some of the nurses do them every 2 years, but because we are primary caregivers for neonates in a home and hospital setting, we actually do them a little bit more. We have to do basic life support or healthcare provider CPR as well. And then we also do emergency skills training, and usually those are entailed for things that are in a hospital and a home birth setting. So it's just things that may come up that maybe we know that there's risk factors for, but also we don't know. So it can include things like when someone's hemorrhaging, so they're bleeding a lot. It can entail if the baby is stuck, what kind of maneuvers, if the baby's coming bum down, traditionally they come head down, how do we kind of deliver those? So we have to do that every 2 years, the BLS every 2 years, just in order to maintain. And then as you kind of continue practicing, we have to kind of document how many births we've done in usually in a 2 year, and then sometimes they do a 5-year window. Again, then they're looking overall how many home births, how many hospitals, to make sure that we are up to date. If we don't have our numbers, we actually have to kind of write to the college and explain like why we are not meeting those numbers. So they're really trying to make sure that in the best interest of the public, that we are kind of doing what we need in order to stay on top of our skill sets and to make sure that we're offering safe care to clients. We also have to do what we call peer reviews. And so that means like we take cases, we review them. It could be things that come up that we can learn from so we can provide better care. And so we kind of collaborate with other teams and other practices, and then we kind of review a few cases, and we do that on a monthly basis. Depending on how long you're practicing in the year, there's a number of them that you have to attend. And then in general, just some education stuff so it can be something like ultrasounds for midwives, or it can be, learning about diversity. So just education things. So we're not just kind of sitting there saying that we're midwives and we're excited to catch babies. We're really proactively, engaging, learning, challenging ourselves. When there's any new changes in the medical field in obstetrics, we're taking courses. So we're actually really actively on top of the deliveries, on top of seeing you in the clinic, on top of making sure your lab and results are normal. We're also doing those particular things. So it's a lot of work, but like I said, if you love it, if you have a drive, then it's worth it. And if you can fit it really well into your lifestyle, it's very, very beneficial. And it's just happiness. Not all the time. I'm not gonna paint that, but you know, I'm smiling here, and it's because, like I said, I've found something that kind of works for me. But don't get you wrong, there are times that it's challenging, and you think, you're like, really, am I doing a good job? Is this where I need to be? And then you get a client who says, I feel redemption. I had a horrible birth experience before, and you know, the birth with you, it was redemption. And that's just all you need to kind of feel like, oh my gosh, okay, I need to belong here, right? So you get those moments at the right time that just kind of tell you that this is where you need to be.
Yeah, no, you always get those signs, but I think it's normal that we always question, like, am I doing the right thing? Is this really for me? Am I going down the wrong path? But like you said, you always get the signs that confirm to you, like, okay, yes, this is what I'm supposed to be doing. I also wanted to know too, like, about mentorship. Is that something that happens with that? Or is it more so like you would recommend people to really do more so research through like books, or maybe like joining organizations or something like that?
Yeah, so how people may get into it, like I said, will kind of be different. So some people get into it because they had a great experience. Some people get into it because they had a bad experience. Some people, you know, they always wanted to get into it, but maybe it wasn't the right time for them. There are some people who were doulas or became doulas in kind of like a bridging to kind of see how it would feel and kind of shift. Do they want to just kind of do that physiological, spiritual kind of part of birth, or do they want to kind of do that clinical management kind of birth? And so once you kind of decide and then you apply, so for example, Ryerson does have mentorship programs, and so they kind of help to try to mentorship students. They are starting to try to help. They have like an Indigenous kind of program and mentorship where they have like actual Indigenous and Aboriginal midwives that kind of help students and kind of support them. They're also trying to have Black preceptors or Black mentors to help Black and African Caribbean students as well. So they are really trying to make it likely for people to succeed, right? You're not going to get more midwives if you have a whole bunch of people that drop out of the program. When you become a student, you have tutors. And you also have preceptors once you get to the clinical placements. And so those are supposed to be your guides, and they're supposed to be the person that also evaluate you, but also help to support you. So I'm not going to lie, and I'm not going to say it's all like flowers and glory. It's just like anything. Sometimes you get a really good mentor and you get good tutors and you get that good support, and then you flourish and you can do really well. And sometimes you don't. And so sometimes that can be challenges and roadblocks for students. And it can make it even more difficult when they're very vulnerable. You know, when I get a student, I see the joy. I see like the innocence, like you see like they're so happy and they're just so excited to be here. And if you're not careful and you don't support them because of the way midwifery can be, they will be broken. And so, you know, if you don't have a really good support system, if you don't have good mentorship, you don't have good preceptors, then it is going to be very difficult for people to make it through the program. And sometimes you'll see people, like I said, take breaks. And if they're able to, for different reasons, then they can come back into the program and they finish. But you also can get a lot of people that just stop and they drop off. And I know really good people that I would say they would have been amazing midwives, and they didn't continue because they just had bad experiences. Some people will finish because they're like, I started it, I just want this goal of being able to say I did it, but then they never ever practice. And then you get midwives because of the burnt out that they end up kind of stopping and not working. So I think there's a call out. We know that these things are happening. We know that there's certain people that are more likely to kind of be targets or drop out or have burnout as well. And we really want to support those people. We need more midwives. People need more midwives. And you can't do that, like I said, unless you're going to support your midwives. So, yeah.
So you also mentioned earlier with that a little bit, like there's different struggles when it comes to like BIPOC and people, Black people, and different things like that. So what are some of the struggles that they may face, and do you see any changes happening? Especially, I guess, within the last year, there's been so much talk about diversity and inclusion and like racial, systematic racism and all those things. So do you see any changes happening within your field?
Yeah, definitely. So when I was at Ryerson in my program, there were like two of us that were considered Black Caribbean. And then that one person dropped out, and then I was like the only one. So once, when it's a little different now, like I said, the way the program works, but at that time, the three schools would once in a while get together for like the big kind of what we call clinical preparations before we would go to our placement. And we went to Sudbury, and Sudbury is not a very Black community at the time. And so I would just remember someone coming up to me, and I was like the only Black person out of like a group of like maybe 65 students, and saying, "Oh, you must feel really weird that you're the only Black person." And at that point, I didn't. Before that point, I really didn't. Like, and then definitely afterwards, I felt really uncomfortable. And I would say my experience overall wasn't too bad. My preceptors that I had were really great. They were wonderful and pretty supportive. I did have some clients that really didn't want me to be there and challenged having me there. Definitely had to be a little bit of racism. But I know for other people, it was a very different story. And so definitely now, I think the biggest thing is that we acknowledge that it's happening and we're trying to do something. Obviously, it's never going to be perfect, but I think because that there's more awareness and more talk and people are being more vocal about it, it's starting the process, but you know, you can't fix everything in one day. It is going to be definitely you know, a process. But like I said, even as a midwife, you know, I do get people that will say that they don't want to have me, or they will change over to like a whole different practice because they don't think I'm a good midwife, or, you know, they will challenge what I will say. But if I'm with a colleague who's not Black, they will challenge that person. And, you know, one of the experiences that I do remember is that in a different language that one of my admin staff could speak, they overheard the client calling me the dark one. And so they're like, "We don't like the dark one." And so, you know, sometimes you get those things, but as a midwife, I'm here to provide care to people who want the care. And I feel that I have the knowledge. And it took a long time for me to even just to be able to say that, yeah, I know what I'm doing. I have that knowledge. I have that experience because of some of those kind of experience that I face. And so, like I said, now where I'm at, I feel like, you know what? I know my stuff. I'm a good midwife. You know, I'm not perfect. There's things that I'm learning. I'm always growing, but I can give really good care, and anyone who wants that care is going to get it from me, hands down. And, you know, it's hard to sometimes get over those challenges. So for me, like I said, I don't experience it all the time. I do get it once in a while, and now I know how to kind of deal with it. Still hurts, but I know how to deal with it. But if you're in a community where you get that all the time, that is challenging. So you really do need your network, you need your association, you need your college behind you, you need your colleagues behind you too. Because sometimes if the discrimination is happening with your colleagues, that's also difficult too as well.
No, definitely. And then you were saying something like having that confidence in your work. So knowing that you can get the job done, you are the best person for it. So do you remember the first time that you had to go in as a midwife, and how was that? Like, were you nervous, or like how did you feel?
Yeah, because that transition from being like a student, and then you have like your preceptor kind of guiding you, even though, you know, they're like, okay, you do everything independently, I'm just going to sit and watch you. It's still very different because you have that safety net. But when you're
Yeah.
there, like you kind of second guess and you have to convince yourself. It's like the little two people on your shoulders. It's like, do this, don't do that. No, do this, do that. But my first birth was a home birth. And so I think because of that, it was just very more calmer, relaxing. And it was someone who had a baby before. And it was just very interesting because she had her toddler there. She was like contracting. And then at some point, like the contraction slowed down. So like you're trying to think, okay, what can I do to keep it going? You know, like, are we going to have to move in? So you kind of challenge yourself a bit. And, you know, the birth happened and it was beautiful. She eventually came back and had more kids with me as her midwife. But it was just like this kind of like the heart jumping out, the palms are sweating, the shaky kind of hands. But then once I did that birth, it's like, okay, like the things that I learned in school and, you know, I passed and they passed me. They obviously didn't make a mistake, right? And you start
Yeah.
to learn how to, you know, trust yourself and it just takes time. You know, you start to go over things. You know, I had the cheat sheets. Like I had I had a little briefcase of all the little cards of all the different things and complications. Now I don't really need to do that. And it's just once in a while, if something that I haven't seen in a couple of years comes up, then I might go on Google and just kind of go through the research and kind of see and navigate it because medical profession, everything in medicine is always changing and evolving. But I don't need to go through that. Like I recently threw away like all my old books and all the old papers and all the cheat sheets because I don't need them. But I had to hold on to them for a long time because I wasn't sure if I needed to
Yeah.
go
Just
back to
like a
them. You know, like
safety net.
maybe just in case. Yeah, yeah, yeah. But it comes. It definitely comes. It just takes time, like anything.
Okay, and then someone did have a question. They want to know, do you work a lot with doulas, or what? Do you work with a lot of doulas, or the responsibilities in your clinic is mainly midwives?
So, like I said earlier, because doulas are paid, it would be the client who would need to decide if they want a doula, and then they would have to seek a doula and then pay out of pocket. Now, there are some doulas that do donate their services, so they will help, you know, marginalized clients, and they may do, like, let's say they're just starting to kind of get their certification, so sometimes they might do free births and support for clients to kind of get the experience under their belts. And so if that client has a doula, then the doula, like I said, is just coming a little bit more for listening and asking maybe questions or just helping to advocate for the client if they're not able to advocate on their own, but they're not coming and doing any clinical stuff. So if a doula is at a birth, it's awesome. More so because as a clinician, as much as, like I said, I'm going to help a person in labor. So I might help to do some back rubs, or I might say, okay, relax your shoulders, or let's get into this position. I'm still a clinician. My main job is still to make sure that you're safe and stable and that your baby's safe and stable. And then I still have paperwork that I have to do. So by having a doula who can really focus on just the client, because they're not doing any of that clinical work or paperwork, then we can tag team to even make that birth experience even more better for that client. So that's how like doulas would be a really good thing. So if the government can come up with a way where they can fund and just give everyone who needs or wants a doula, that would like be like amazing. Like the government really needs to think about that.
Trust me, I think that would be great if people were able to have that access. So I'm hoping one day that happens, or maybe a group of people will advocate for it, because I think it's super important, and I think it would be very beneficial. But that's all the questions that I had. Am I missing anything? Is there any information that you think is needed for somebody who's thinking of midwifery?
I think if you feel like you're interested, definitely go for it. A lot of the schools do have some kind of information night or a session night. Again, with COVID, it might just be more virtual. do your research. You know, I'm happy if people want to reach out to me and ask some questions. I'm not one of those people who, you know, no, we don't need more midwives, or I want to be the best. We need more midwives. We need more people out there. There's no way that the amount of midwives that we have can reach everyone. And we know midwives are intricate in helping with the maternal health crisis. There's a crisis. We know that people are dying giving births in this day and age. We can do something about it. So if there are people that are really serious about it and they want to take it on, all you need to do is just kind of do your research and kind of look into it. That's at least the first step. And then if you feel like it is something that you want to take on and you're serious about it, then apply for it. And the great thing, like I said, is sometimes some people will take a little bit more time. Ryerson's a good option. They have a part-time stream. At the time when I went, they had a 4, 5, 6, 7-year stream. They don't have that option right now, but they do have kind of like an extended stream. So if you need to take a little bit more time, definitely that can be an option. I have students that I was preceptors for, that they just take a little bit more time, but they, you know, that's just what they needed to do. And they're awesome, awesome midwives too as well. And I know friends that they took a little bit more time and they're also awesome midwives. And that's okay. There's nothing wrong with that. You have to kind of go at your pace. And like I said, it's a journey. It's a journey to kind of get there for sure. But if you're interested, definitely take that first step in doing your research, looking into it. It's really great. I think the one thing that I didn't get to talk about, because we talk a lot about like that we get to catch babies, we get to stay with the families and share, but the other side that, not that I enjoy, but I like that I can do this for families, is people who have birth babies that don't make it as well. Right. So those people, if they didn't have a midwife, they would be facing a lot of those things alone. And so as a midwife, I can still be there for them. And so when I think of some of the families that they're not taking their babies home, you know, some of the words that they have said is that if they didn't have my support or the midwife support, they would have been very alone. They don't know how they would have gone through, because we don't just stop just because they're no longer pregnant. We're now navigating and telling them the things that maybe they don't know, like your breast milk still comes. You don't have a baby, but you still have breast milk. You're still going to have aches and pains. You're still going to have some bleeding. So by taking care of those people too as well and supporting them, you know, even if it's going to be a very sad moment, even if they're going to have moments where they feel very broken, at least they don't have to do that alone. And I think that's also just as beautiful. It's not the happy, joyous moments that we are expecting when we're thinking of pregnant clients, but it is still something that is very, very important. I'm a really big believer of mental health too as well. And I think by having a midwife, I think that's another specialty that we have and the connection that we have with our clients. So. Yeah.
No, I think that's also important too. So thank you so much for bringing that up, because as you mentioned before, like sometimes when you have the birth at the hospital, you're mentioning like you have different people, the shift changes, whoever's at the hospital at that time. And I do find sometimes, like, even if you do have your baby, I feel like the process is kind of rushed. I feel like you don't get to stay in the hospital as long as you used to before. I feel like they kind of just like, you know, you have the baby and like you're out. Or if you do go through something like a loss, it's kind of like the same thing. You don't really have anybody there. It's kind of like, okay, we just need to kind of get you out of there and back home. So I think it's really important, the work that you do, because you're really there for the person that is having birth, for the family, for both ends, even if they're dealing with like postpartum depression and stuff like that, you work with them through that. So I think that's really important.
Yeah, I agree. And just in terms of rushing out, definitely you don't want to stay in the hospital because there's a lot of germs, if anything, but I know what you mean by it's a system, right? Like, so there's a checklist and it's kind of like boom, boom, boom. Okay, everything's done. Definitely as midwives, we do take a little bit more time. And it's, again, not to knock down like what doctors or nurses do, because they're amazing. And if there's something that's high risk or some reason why we work really well with them. We can collaborate really well, but it's just a different philosophy. So if you're thinking again about being a midwife, look into it, research, think about like what kind of philosophy and what kind of care you want to give to clients. So like I said, do you want to just provide physical, emotional, kind of spiritual support? Then maybe being a doula is good. Do you want to kind of provide that natural, informed choice? You're working with a smaller group of clients, but you're more intimate than being a midwife is all about. But if you want to deal with more maybe high risk, you like doing things like surgery, maybe you want to do C-section, maybe being an obstetrician might be kind of a path that you want to go. So it's kind of just like doing your research, kind of figuring out where you want to be. Each of those professions are very important when they play their role correctly and we all collaborate and feed off each other, then that's when people are going to get the most beneficial care. So again, it's like we want to start focusing on client-centered, family-centered care as opposed to like, specialist kind of care.
Yeah. No, exactly. No, I learned a lot from this. So I want to thank you so much for taking the time out again to do this because, yeah, we received a lot of information. I'm probably going to go through the whole interview again just to take in everything. But thank you so much for this.
No problem. Thank you so much for having me. It was so much fun.
Thank you.
And
So
I'm sorry. I'm glad I figured it out. So hopefully next time it'll be a little bit easier if we have to have a part 2 series.
no, definitely. I would definitely like to, get this stuff out there because I do want to reach people who aren't aware of the many options that are out there. A lot of people think like just nursing in that one form is the way to go, but there's just so many different avenues to take. So I just want to highlight different careers that not too many people know too much about, and maybe that can help them choose what they want to study or what field that they want to go into. So this was really great. So I appreciate it. Don't worry about IG. I'm still figuring this out too. I'm late to the game. Don't worry about it.
Thank you so much. I was trying to look for the ice cream scientist video because that is interesting. I saw that you had it.
She's amazing. So on my page, or you know what? I'm gonna send you the link to your email so you have it, or in like a DM. Don't worry, I got you.
Thank you.
No problem. Have a good night. Thank you so much.
Thank you. Thanks for everyone for joining.
All right.
Okay, bye.
Bye.